Hey there, it's Nurse Mo again. I'm getting ready for work, and I thought it might be beneficial to talk to you guys about a quick SOS routine. If you've read my book, you know I talk a lot about routines, I talk a lot about time management, and an SOS is a start of shift routine. And I've learned that by following a set routine at the beginning of your shift, you really set yourself up for being organized and managing your time really, really well. So obviously, the very first thing that you want to do at the start of your shift is get report. And typically in the ICU with 2 patients, that's about 15 minutes per patient. So it's a really long report. Here's a sample of my report sheet. I carried around on my little clipboard with my name on it. And there you go. You can kind of see it. And these are on my website too. So you can download them and play with them at your unit and see how it works. If you're on a med-surg floor or surgical floor, tele floor, someplace where you've got 4 or 5 patients, I don't know, maybe in other parts of the country. I'm lucky I live in California where we have ratio laws, but I've heard some stories about other places where you'll have 6 or 7 patients and there's not time for a really long report. So you want to make sure you get through report, get the most pertinent information so that the offgoing nurse can get out on time. Very first thing that I do. After that, I'm going to get into the computer, take a quick look at labs. If we didn't go over any outstanding labs during report, I'll look and just get a quick idea. The most important ones that I'm going to look at are the H&H, the white count, the chemistries, mainly the electrolytes that have anything to do with cardiac physiology, and the clotting factors. Those are the ones that I'm going to look at first. Then I'm going to take a look at the MAR, and I'm going to fill out what I call my run sheet, and I'm going to show this to you. So this is what I use to keep myself organized with the times that I need to do things, the meds that I need to give, the labs I need to draw, and the charting. There's Q1 hour, Q2 hour, Q4 hour, daily, just once a shift, as needed, and at the end of shift. I also have an end of shift routine. And this is for ICU patients, so what I will do is on this side, I'll write what I need to do in that hour time, and then on this side, I'll write down anything that I need to chart and attribute to that hour, like urine output, or patient got out of bed to the chair, or any changes that I need to write about. So that's that. So there's one patient on one side, one patient on the other side. I fold this baby up and stick it in my pocket. So that's my run sheet. Fill that out. Get a kind of a rough schedule idea and know what meds that my patient's going to be taking and what time I'm going to be giving those. And then I'll run a quick EKG strip. If your patient's on any kind of telemonitoring, you want to run an EKG strip. I'll check the QT interval. Some of the meds that we give in the hospital are going to prolong that QT. I think I'll do a whole post about QT intervals. It's really interesting. Lots of meds. I think Levaquin is the one that sticks in my mind that causes a prolonged QT. And then there's meds that you do not want to give if they have a prolonged QT, like Haldol. So it's really important to know what that QT interval is at the beginning of your shift so you can watch for elongations, especially if they're on any of the medications that can prolong that QT. And also you just want to get an idea of what their rhythm is when you start so that if there's a change, you know. So next I will try on a good day to look at one note per patient, and that would be the last note that the MD wrote and any consulting MDs. You don't have to go back and read the whole chart. Just look at the note that the MD wrote that day if you're coming in on night shift, or the note from the prior day or the prior evening if you're coming in on day shift. So get a kind of an overview of the patient with that note and the significant events for the last 24 hours. So that's a really good place to go. And then I will jaunt off to the supply room or the med room and stuff my pockets with things, get all my equipment together. So never go anywhere without one of these hemostats. I use this more than anything else. I got fun ones so that I would know they were mine. So that if I leave them somewhere, I know those are mine because these will get lost. People will pick them up. Ditto. Oops. Shake. Sorry. Ditto with the scissors. I got cute scissors. Nobody else is going to want to carry my flower scissors, so they've never been stolen. And I'll shove a bunch of things in my pockets. Definitely alcohol swabs. Got to have a good stack of those. No matter how many I pull, I will run out half an hour before shift ends. Guaranteed. Doesn't matter. Weird. And then I'll get some dead enders. So if I'm moving IV lines around or disconnecting IV lines, I can put a sterile dead ender on it. Don't ever loop it around to the Y site port. That's just lazy. Just carry a few of these in your pocket. I might carry a few of the end caps for the IV lines, maybe one or two. I might throw a lancet in there. It seems like if I've got someone with a difficult finger stick and I've only grabbed one lancet with my glucometer, I'll be really happy that I have that other one. So I've got my pockets, I've got my pens, ooh, don't forget pens, my steth, hemostat scissors, I'm good to go. So then I'm gonna go into the room. I will do a quick head to toe assessment. We do bedside report at the unit that I work on, so when I'm in there for that, I'll do a very quick focused assessment pertaining to why they're there. So for instance, if the patient's there for, let's say, neuro, we're going to do a bedside neuro exam together, me and the off-going nurse. That's just policy. If they're there for, maybe they broke their femur or something, if you're working in a trauma unit, then you want to assess pain, things like that. If they're there for respiratory, just real quick, as you're talking to the patient, are they speaking in full sentences? Are they short of breath? What's their O2 sat? You're not going to pull out your stethoscope and start listening to everything, but just a real quick focus. Okay, I kind of have an idea where they are. Then you're going to go back in and do a full head to toe. When you're a nursing student, you will never understand how this can be done in less than like 15 or 20 minutes. You'll be getting really good at these and doing them really fast. So you'll do your head to toe, and then you'll have a quick conversation with the family or the patient if they're awake and alert about what the plan is for that day and setting some goals with them so that they understand what's happening and can participate in their care. So there you go. That's my start of shift routine. So I hope that helps you get a nice solid start of shift routine going. Obviously make one that works for you, where you work, your unit, the type of patients that you see, the workflow, all of that. But I find that if you stick to a consistent routine, you're going to get off to a good start every shift. I'd also like to invite you to listen to my podcast. It's under Straight A Nursing at iTunes. If you search for that, you will find it. I talk about all kinds of great things. And you can go to my website if you haven't been there yet at www.straightanursingstudent.com, where there are tons of resources for nursing students, new nurses, anyone wanting to review any topics. It's all right there, www.straightanursingstudent.com. You can also follow on Twitter at straightanurse, on Instagram, straightanurse, or on Facebook, look for facebook.com/straightanursingstudent. So I hope you guys all have a productive and wonderful shift.